Our next speaker is Dr. Ramin Eskandari. Dr. Eskandari is the Chief of Pediatric Neurosurgery at the Medical University of South Carolina. He joined MUSC in 2014 and has been a vital proponent for minimally invasive surgical treatment strategies for patients with hydrocephalus, pediatric epilepsy, and brain tumors. He completed his undergraduate studies at Wayne State University, completed residency training at University of Utah, and fellowship at Stanford University. At MUSC, he has helped establish the ongoing Pediatric Neuroscience Research Fund to promote and advance collaborative research through pediatric neurosciences at MUSC. Dr. Eskandari serves on the Medical Advisory Board of the Hydrocephalus Association. His strong passion for education and academics has led him to mentor over 20 students and to author and present over 50 papers. As a reminder, there will be time for questions and answers after the session. Please type your questions in the Q&A feature at the bottom of the screen, and we will try to get to them all.
Good morning. So I want to thank the Spina Bifida Association for the invite and Jenna for reaching out and having me talk. The topic of the talk today is going to be one that hopefully resonates with a lot of the audience, but hopefully hasn't been an issue with a lot of the audience. It's one of a surgical nature, including tethered cord in patients with spina bifida and myelomeningocele. And I chose the arrangement of this talk around a specific case study. And I thought that might be a good way to go through sort of the entire set of challenges that we face in neurosurgery. And Dr. Alam is going to probably speak to a lot of this in the afternoon session with diagnosing and treating tethered spinal cord. As we'll see with this case presentation, things don't always come easy to us as far as diagnosis, even with some of the more sophisticated testing methods we have. So this is a case of a 3-year-old girl with a history of a known myelomeningocele that was diagnosed prenatally. After she was born, she was found to have a very thin covering of what we call dysplastic skin over top of the defect. And when I say dysplastic skin, it just means that that's the area of the myelomeningocele, and so that's not really viable skin. She still needed a closure. Now, the good thing is that in her case, she did not have any leakage at the time of birth. So her myelomeningocele was closed on day of life 2. She did have a Chiari-2 malformation, which I heard earlier was a question from the audience. And by definition, patients with Chiari-2 malformations are linked to myelomeningoceles. She did have ventriculomegaly, which means that the fluid spaces, the ventricles within her brain were enlarged. And as typical, when we close these myelomeningoceles, their ventricles do tend to enlarge after closure, and hers did as well. However, just like we've hopefully seen over the last 10 to 15 years, there's been a shift in treating increased ventricle size with either shunting or other surgical procedures for hydrocephalus to being a little more conservative and watching over time. And in her case, we did exactly that. She didn't have any signs of elevated intracranial pressure. And so over the first few years of life, we followed her along with intermittent fast brain MRIs that progressively showed slight decrease in ventricle size and increase in overall brain thickness, which is fantastic. So she learned to walk and run and perform pretty much every normal function you can imagine as a young toddler, including urination and bowel movements. Now, she did have some accidents here or there, but given the age, we didn't think anything was out of range for normal behavior. Shortly around her 3rd birthday, her family did notice that she was becoming a little more tired in her legs. She'd start to kind of complain when they would go on longer distance walks. Got to a point where even walking around a mall or around the neighborhood, she'd ask to be picked up. And overall, her height and her weight and her head size were all pretty much normal when we measured them. So this prompted us to get some imaging. And these imaging modalities that we obtain are typically MRI. And so in cases like hers, when we obtain imaging, we're looking specifically for things like fluid collections. And if you look on the imaging here, I'm going to show you, these are pictures that are cut sort of right down the middle of the patient. We're looking from the side. And this right here is the spinal cord, and the white that you see is fluid building up within the spinal cord, and that's called a syrinx. This will become important later on. In this part of the image, this is the neck, and what we're looking for here is the level of the Chiari-2 malformation. So this is at the base of the skull. You can see this is the cerebellum, again, a side view. And this area right here is the Chiari malformation, where the brainstem has been pulled down. And then this picture is at the level of the very bottom of the spine. So this is what we call the lumbar spine. And again, you can see the fluid collection building here. And the reason why we get all three of these is because we want to get a full evaluation of overall what the spine looks like and what the spinal cord is doing. And in her case, we see that the tethering area is down in this area, in the very lower part of the spinal cord. The spinal cord is being pulled down. Normally, it ends right about here. Hers is being pulled down, and that's because of her myelomeningocele. So over time, we got baseline imaging here in 2018, right around her 3rd birthday, again, because of her increasing symptoms. And the baseline imaging, again, was to evaluate the Chiari, look for possible syrinx, which she did have, look at the tethering location and the severity and the anatomy. But again, it's very important, this is not a basis for surgical decision-making. Surgery for tethered cord is risky, and so it should be done based on symptoms and not just based on imaging. But we have imaging as a modality to be able to follow patients. Just a side note, we did get brain imaging at the same time to make sure hydrocephalus wasn't the reason for all of this, and it wasn't. So over time, we got more and more imaging, and we followed her along. Her symptoms were not getting better, and slowly they were actually getting worse. And so again, this is representative imaging now in November of 2018, showing the very bottom of the spinal cord, the syrinx, the fluid collection, and the syrinx here in the what we call the thoracic spinal cord. She did undergo a tethered cord surgery in December of 2018, and we're going to go to that surgery in a second. But I wanted to show you that even after her tethered cord surgery, her syrinx never got smaller. And in fact, over time, if you look at March 2019, then July of 2019, her syrinx actually can continue to get worse even after her tethered cord surgery. And that becomes very relevant later on. So by way of improvement after her tethered cord surgery, 3 months post-operatively, she had improved walking distance. She showed improved walking speed. She was able to start climbing stairs more readily. And before her surgery, it got to a point where she really wasn't wanting to climb stairs at all. She did have less accidents immediately after surgery and was complaining less of her legs being tired. But as I pointed out earlier, her syrinx did not get smaller. And so unfortunately, over time, over the next 3 to 6 months after her detethering surgery, her syrinx started to get bigger, as we indicated here. And now it was going up into her thoracic spine and not just in her lower spine. So the hardest part about this, and this goes into the diagnosis and challenges that come along with tethered cord, is that what is a syrinx symptom? And so in her case, she started to have rebounding of her bowel accidents. And so this became a question, and her family and I went through multiple rounds of discussions and sort of iterations of what could this be from. She had assessments by the urologist, trying to see if there was any link to the potential bowel symptoms that she was having. It was a very, very challenging time because we didn't know whether her syrinx, which obviously was getting worse, was contributing to just bowel symptoms versus all those other things that had gotten better from the detethering operation. Ultimately, the decision was made to go ahead and do a surgery for the syrinx and to try and decompress the syrinx. That decision came after months and months of back and forth with the family about whether we should take those risks or not. And in her case specifically, we felt that the progressive increase in syrinx size was ultimately going to cause a problem. And so if we can address it earlier rather than wait until the symptoms became very, very much worse, it would benefit the patient. So in her case, we went ahead and did what we call a syrinx subarachnoid shunt, which is placement of a small tube into the fluid chamber of the syrinx, and you can sort of make out just the very faint shadow of the tube going into the syrinx. And this immediately, within a few months, decreased the size of the syrinx, as you can see from here to here, almost completely gone. And the thoracic area of the spinal cord is almost completely back to normal without a syrinx. So what's interesting in this case, and what we will hopefully over time learn more about, especially with Dr. Alam's talk in the afternoon, is after the syrinx had obviously improved with imaging, she had no improvements in her bowel accidents. And so even though we had discussed that this could be the case and that the bowel issues might not be related, unfortunately, she didn't show any improvement. She did have less as in the way of waking up at nighttime, complaining of pain and sort of achiness. And so the sensory symptoms that may have been from the syrinx did improve. Now, why did this all happen? I think it's important that we go back and we look to see if there are signs that either we could have seen earlier or that one should look for over time as triggers to say maybe these are times when some of these pathologies, some of these tetherings could start to happen more often. And in her case, it's interesting when you go back and you look at her growth chart in our medical records, you can see that over time, this is when she was born, and this is 24 months of age, she had a very normal progression in her length, somewhere between the 50th and 85th percentile over the first couple of years of life. And again, during this period of time, she was pretty much asymptomatic. Now, what's interesting is if you start to go after that 24-month period when she was turning from 2 to 3, you can start to see that there's some interesting things that happen. First, she had a very quick growth spurt from the time that she, right around the age of 3, so kind of in the few months right before 3, she popped from the 50th percentile all the way up to the 85th percentile. Now, that also correlates with a flattening of her growth curve. So it was the first time, if we go back all the way from birth, that she had a halt in her growth. This also correlated with her signs and symptoms getting worse. So this makes sense that this sudden growth is what pulled on the spinal cord. And unlike the rest of her growth, which was gradual over time, this sudden pull from her spinal cord was probably what set her over the edge. So this is the time of her detethering operation, and as you can see, after that detethering operation, she went back to having a normal growth curve, which she showed even before 3 years of age. This is the point at which her syrinx grew, and so question whether these were signs of syrinx, as we talked about before, and or not, but that was the timing of her syrinx decompression, fenestration, and shunt, and you can see that after that she had more rapid growth in her length, and the syrinx improved at the same time. So even though we did do surgery here, it seemed that her syrinx getting smaller was linked to another growth increase. So what is there in the literature on this? And it's important when you look back in the literature to see how could you improve future patient care, and whether what you're doing is really evidence-based. And so in cases of tethered spinal cord and syrinx, the diagnosis of tethered cord is quite challenging, especially in the spina bifida and myelomeningocele population. There's been studies that show that inherent lumbosacral nerve dysfunction, so the nerves that are at the very bottom of your spinal cord, can sometimes dysfunction just from the myelomeningocele itself, just from development of a myelomeningocele in utero, and sometimes even after birth, those nerves can continue to dysfunction. And that can very much mirror some of the symptoms of tethered cord and syrinx. And so having a syrinx does complicate the matter. And so if you look at diagnosis of syrinx in the patient population, it's very, very common to have that diagnosis in postnatal patients. But when they looked prenatally, they only found that it was present in 2 out of 2,000 plus prenatal MRIs. And so initially, we all sort of assumed that this is probably congenital, it's been there forever, we should only really worry about it if the symptoms get worse. But in a study out of the Journal of Neurosurgery Pediatrics in 2014, they looked and they found 109 patients with neural tube defects, so spina bifida is an example of that. And they found that in those patients with neural tube defects, it's even more rare to find syrinx in utero. Only 0.9% of those patients had any kind of signs of the syrinx in utero. However, postnatally, it was found in up to almost 50% of patients at follow-up. So obviously, spina bifida is linked to having a syrinx, but the syrinx is developing postnatally. And so therefore, it's an acquired finding. This means that we have to evaluate. We can no longer assume that this is a congenital finding. We actually do have to look for it. We should probably be doing baseline imaging of the spine at some age. The question is, when does it develop? If you do your first MRI of the spine at 6 months, are you going to find it? Should you do it at 5 years? When should you do it? When the patients start to have symptoms? And this, unfortunately, hasn't been answered yet, and it's still up in the air. Also important is that just having a diagnosis of a syrinx does not mean that patient needs surgery. About 60% of the patients with syrinx will have symptoms of the syrinx, which means 40% won't. So that's close to half. Just because you have it doesn't mean you have to have surgery. What's important is, can you differentiate the symptoms between a tethered cord and that of a symptomatic syrinx? And that becomes very, very challenging. The studies that have been looking at this over time have said over and over again that one should address the tethered cord symptoms first, if they can differentiate them well, and then address potential hydrocephalus, which can be in the form of a shunt malfunction if a patient does have a shunt, and then address the syrinx last if everything else does not get, if other treatments don't improve the symptoms, which goes along with what we did in our patient. So I'd like to take a little bit of time and go through her operations. Specifically, I do have an operative video, and so I thought, since there's a lot of patients and families, many may not have ever seen an operative video, and I thought it might be interesting for them to see what we do in neurosurgery when we take your loved ones or yourself to surgery. Now, it's not gruesome or anything. Actually, we find it very beautiful, but again, it's a forewarning. The next slide after this will be an operative video. If you're squeamish, you can turn away for the next 7 or 8 minutes. So in our patient's case, her first surgery was what we call a lumbar laminoplasty, and I want to take a couple minutes here and show you exactly what that means. And I think this is important, especially in pediatric neurosurgery. Attention to detail, I think, is extremely important. As our previous speakers mentioned, transitioning from pediatrics to adults, both in cognitive and neurological function, as well as spinal function, are very important. And so in a laminoplasty, you take the bones that are in the back. This is a sort of an animation view of the back of the spine. These are the bones that you feel if you were to feel your own back, what I call the dinosaur bones. And these are the nerves coming out, and the spinal cord is underneath. So normally, we would just remove these bones and do the surgery and not put them back on. And in a laminoplasty in children, we take those bones off and we put them back on. And so after that bone comes off, you're looking at the spinal canal here. This is the covering of the spinal cord, the dura. And once we open this and do our surgery and everything goes well, we put the bones back on. So replacement of the lumbar bone is done with absorbable plating system, and these are little fasteners that are made of almost like a sugar substance that absorbs over time. So no titanium or metal that we leave in these kids with growing bones. And then screws go in and hold them in place, and over time their own bone grows into every part of this. They have a much more normal bony anatomy as they grow older. And also, you have to remember, these are patients that typically do already have missing bone in the back because they've had a myelomeningocele repair. And so just having had that at birth and having skin over top means that they're missing bone. If you were to remove even more bone, that's even more of a posterior protection that they don't have. So putting it back on makes all the sense in the world. In our patient, we also did something called resection of an inclusion cyst, a dermoid cyst. Now, this is a quite a common finding in kids with myelomeningoceles. As we close these in utero, they're finding more and more of these. The fetal surgeries have increased in numbers of these dermoid inclusion cysts, which can cause tethering of the spinal cord later in life. Basically, it's some skin cells that get trapped during the closure. And so there's not a good way of preventing that aside from cutting off the entire bottom of the spinal cord, which we don't do anymore. This is a very old method of treating these patients. We don't do that anymore. So microscopic skin cells start to slowly grow. They're usually not a problem except when they cause tethering of the spinal cord. Her second surgery after improvement of her tethered cord symptoms and lingering bowel issues was the syrinx operation. And we talked about that, her syrinx to subarachnoid shunt with release of fluid. She had complete resolution of her syrinx symptoms, which we felt were more sensory than anything else. And bowel management with a very good bowel protocol has helped her immensely in her not having accidents anymore. So I'd like to play the video and sort of go through as we do the video and take you through the surgery. When we're looking here, if you think back to the animation that I showed before, here's the bone of the level above the laminoplasty area. Here's the opening and you can see the dura, and then here's below. So again, head this way, patients laying on their belly, feet this way. You can see the dura being opened. We're opening the dura under heavy magnification here. The dura itself is very translucent. As you can see, the instrument here is underneath the dura, but not touching the spinal cord itself. And you can see the instrument through the dura. So it's completely translucent. It's very, very thin. It's nice and tough. It can hold suture and it can withstand being pulled, but the thinness is about the thinness of a wet piece of paper Kleenex. As we open the dura, our goal is to prevent any injury to the contents underneath before we have a chance to be able to release those contents. One of the biggest problems with kids that have myelomeningoceles is that after we close them, the area of closure, which in this patient's case is further down below, that area is already scarred. And so if you try and go in over that area, you're going to fall into major scar. So we start above the area in more of a normal area. And here's the spinal cord, the very bottom of the spinal cord. You can see it was tethered. It was caught to this piece of dura here. But that was unfortunately the very beginning of the tethering. And so when we say tethering, remember, tethering means scar tissue, means adhesions, means something is holding it in a position that it's not natural. And so this is the very bottom of the spinal cord, and so we're very gently moving the spinal cord aside so we can get to this scar tissue right here. And with very small scissors under magnification, we slowly cut away the scar tissue that's holding the bottom of the spinal cord. And as we do that, we start to see something that we didn't see on the MRI very well, and which is this tiny little inclusion cyst. Now, this cyst itself is probably on the order of 4 or 5 millimeters in size, which is extremely small. But when you're talking about something foreign down here in the spinal canal, that's enough to cause tethering. You can see significant amount of scar tissue that's built up around the spinal cord and the cyst. The cyst is, you're going to see it come into view in a little bit, but it's caught on the dura. As we slowly open the dura a little bit more, You can see all this is nerve tissue. These are vessels on the nerves, and then the cyst is coming into view here. So all this is fluid. The cyst is made out of fatty skin cells, and if you look carefully, sometimes you can even see the appearance of little bubbles inside the water, almost like oil in water, and that's exactly what it is. The cyst is more oily, and the spinal fluid within the canal is water. And so our goal when we're taking this cyst contents out is not to try not to release that cyst content into the spinal canal. It's sort of like making salad dressing inside the spinal canal. You don't want to do that. It irritates the spinal canal. So as we release the spinal cord, now technically we've detethered everything here, and there's some little adhesions left, but this instrument that you see coming into view, this long metal probe, this is an electrical probe that's testing to see if there's nerves within this area. So we have to be able to open the cyst wall to be able to remove the contents of the cyst and hopefully thereby decrease the risk of future tethering. But in order to do that, we have to make sure we're not cutting through any active nerves. So we test that during surgery and make sure there's no active nerves there. Here you can see us cutting into the cyst wall, and you can sort of start to make out the contents of the cyst. And as our instrument goes into the cyst cavity, it's releasing those skin cells and fatty tissue that's built up over the course of a few years. And we just slowly remove the inside contents very carefully, not to disrupt the nerves and the spinal cord below or all around, which are all attached to the wall of this cyst. Now, important to mention, any other time that you have this sort of condition, you would physically remove the entire cyst, including its walls, including its capsule. That's the way to guarantee that it won't come back. Unfortunately, in a spinal cord situation, obviously, everything next to it is important. You can see these nerves running all around it, the blood vessels that are coming in. You can't sacrifice any of those. Those are all functional. And so the best that we can do is to completely empty the contents of the cyst. And then at the end, you'll see that we actually put stitches into the cyst to try and close it off to decrease its ability to regain size and regain its tethering potential. Here we're just sort of trying to release the wall of the cyst so we can put stitches into it. Once again, this sort of surgery is done with what we call neuromonitoring. So the entire time that we're doing the surgery, there are electrodes within the patient as she's asleep, and the neurophysiologists and pediatric neurologists are watching to see if what we're doing is causing any irritation to the nerves. If it does, they give us a warning and let us know that things are being irritated. We can do the monitoring like I showed earlier and test to see if any nerves are functional. So that is an extremely important part of the surgery. Here you can see that we're putting a very small suture inside of that cyst wall to close it off. And the difference between this picture now and if I go back and show you before we decompressed it, this picture is quite dramatic. So a big difference now in a detethered situation. You can see the nerves are all very much loose. Everything's hanging much better. It's not attached to the dura, to the overtop covering. And then from this point on, we close the dura, which is the covering of the spinal canal, with suture. And you can see here's the bone being put back on. So we saved this and we put little plates on it. Here are those plates, the fasteners, and those fasteners are coming up and holding this piece of bone. And then the sides will drill holes into into her normal bone, and then put these little tiny screws, which the screws themselves are also made out of that same absorbable material that over time completely goes away, and you're left with normal bone covering the defect site. We also suture the ends of the bone to the normal ends of the spinal, bones that are still in place. And that helps to hold everything in place. Here you can see us putting suture into the bones here and attaching it there. So obviously we love to see success stories. And in cases like this, one of the things that I always say is that we are happy to see that our successes are duplicated in the patients doing well when time goes on. This patient did very well. She left the hospital. She continued to do well, like we talked about before. Her syrinx, after doing the syrinx surgery, got smaller as well. And so we really want to, I want to show the, unfortunately this video looks like it's sideways, but it's going to show her running. 1 year later, she's basically racing a scooter and able to run around very nicely, not having any problems. Thank you very much, and I'd be happy to take any questions at this time.
Thank you so much, Dr. Iskandari. That was really impressive and a great video. And we had a couple of people comment about how good the video was. So a couple quick questions. Somebody wanted to know what the level of Harper's spina bifida was.
That's a good question. So in all honesty, sometimes it's really tough to know exact levels. When patients are born with myelomeningoceles, we tend to not concentrate on exact numbers of levels as we do location, general location. And so by definition, if a level is what we call sacral or lumbosacral or thoracolumbar, we're describing a region, not necessarily a specific level. And the reason that becomes important is that because this is a developmental phenomenon, the bones, the way that we number levels is all based on the bones. And so if certain bones are missing, your numbering is going to be off a little bit. And so the best way that you can describe this patient's level is to call it lumbosacral. So it's affecting the bottom of the lumbar and affecting the sort of sacral area. Another way that you can know levels is by looking at function. And so someone who has only bowel and bladder function tends to have levels that are very much lower. As patients start to have functional loss in their legs, in their feet, and and the upper parts of their legs, their levels start to ascend. And so when you're not exactly sure what level, sometimes you can base it off of functional disabilities. Now, in her case, she didn't have any lower extremity functional disability, and so we think hers is more of a lumbosacral.
Okay, so a couple of people have also wondered what the syrinx is.
Great question. So a syrinx, by definition, is a fluid collection that has built up within the spinal cord tissue itself. So some people have equated it to hydrocephalus of the spine. And it's not a completely inappropriate definition or analogy, but in general, the normal spinal cord has a very thin tube called the central canal. This acts sort of like the ventricles in the brain in that it circulates spinal fluid. In cases of myelomeningocele and some other disorders, that fluid doesn't travel all the way up and down and leave the spinal cord normally. It gets trapped. And if it gets trapped, depending on the level and how severe that trapping is, fluid will start to build up within the spinal cord. And sort of like an animal balloon, that kind of elongated balloon that you make animal things with, if you imagine like that, a water balloon within the spinal cord, if you let it go, it will continue to expand from the inside out, pushing the spinal cord tissue off to the side.
Okay, thank you. So what is the recovery time for detethering surgery?
So that, unfortunately, there's not one answer for that. Detethering operations are extremely risky operations. They have a very high risk of causing more neurological deficits than what you started with, unfortunately, because some of that scar tissue, in Harper's case, we were lucky because we had scar tissue that was more attached to the dermoid, to the inclusion cyst, than it was to the spinal cord tissue itself. And so we were able to cut away a lot of that scar tissue, as you saw, and the probe indicated to us that that was not viable nerve tissue. In some patients, that's all nerve tissue. They don't have an inclusion cyst as their cause of tethering. It's just the nerves themselves. And so in those patients, the recovery time is much, much longer because they end up having more neurological problems after surgery than what they started with, which is not an uncommon thing. Now, thankfully, most of that recovers with time, but depending on how much of a difference there is in function, sometimes they need rehabilitation. And so that could extend the hospital stay and the recovery time from a couple days to potentially weeks.
Okay. And another question about syrinx. Is syrinx always present with symptomatic tethering?
That's a great question. It is not. So I would say more often than not, symptomatic tethered spinal cords do not have a syrinx. There's definitely association of developing a syrinx as part of a cord tethering, because one of the things I mentioned is the syrinx develops when the fluid can't exit. And if the spinal cord is too tethered, the fluid can't travel appropriately. So then it could potentially develop into a syrinx. But by no means is that always the case. And a lot of times when we do the imaging, what we're doing the imaging for is not to document that there is a tethered cord. We know that all of these patients, by definition, have a tethered spinal cord on imaging because of the myelomeningocele that was closed, whether it was closed prenatally or postnatally. They're always going to have some nerve tissue stuck at the very bottom of the canal. The question is there something we can do about it? And that's when the imaging is done. If there's a syrinx, now we start to think, should we be doing surgery about it? So it's not 100% of the time.
Okay. And could tethered cord syrinx affect mood?
That's an interesting question. I would think that it could, mostly because it's probably also associated with age. So if you think about a patient who is a toddler, 1 to 2 years old, they don't really have great communication skills yet. They can't express themselves. They don't necessarily know all of what pain means and how it can affect mood. If they're not sleeping well, if they're uncomfortable, that can definitely affect mood. I mean, some of the kids that we've treated in the past, their presentation has been increased irritability. And when you start to look into it and start to do the various testing and the urological tests and whatnot, you start to notice, oh my gosh, they do have either a tethered cord or a syrinx, and that's the cause of their discomfort. So I would think that mood can be affected because of the discomfort.
Okay. And here's a question that I hope I don't mess up, but is dolphin neurotism treatment a viable treatment for pain function in a patient who is not a good candidate for another detethering due to complications such as a large pseudomeningocele and history of meningitis?
I have no idea what that treatment is. Can you repeat that one more time?
Dolphin neurotism.
Okay. Maybe we can ask the person who asked the question to elaborate on that treatment, because I'm not sure what that is, and we can come back to that question.
Okay, yes. So Demery, please ask your question again, and in the meantime, we'll take another one. So one of the persons that had asked about syrinx said that their 19-year-old son had been experiencing symptoms, possibly of tethered cord. A new doctor that they met mentioned it could be Chiari related. The son had tethered cord surgery at age 6, but has never had Chiari surgery. So, yeah.
So I'll start by saying that doing surgery on a Chiari-2 malformation, which is the type of Chiari that patients with myelomeningocele and spina bifida have, is very, very different than doing surgery on a Chiari-1 malformation, which is not associated with spina bifida. And the reason I say that is because there have been many, many studies over the course of the last 20, 30 years that have continuously said that outcomes after Chiari-2 surgery are not very good. And I'll sort of go into that a little more detail. So a Chiari-2 malformation, even though it has the name Chiari, is not the same at all as what a true Chiari is, which is when the bottom of the cerebellum comes down and pushes on the spinal cord and brainstem. A Chiari-2 malformation, by definition, does not have to be compressive. It does not usually cause symptoms. It's from a developmental anomaly of the fluid being drained out of the bottom of the spinal canal and the entire brainstem sagging down and developing in the wrong location. So Chiari-2 malformations are usually associated with brainstem dysfunction and not from symptomatic compression or pressure. Now, that does not mean that there are not exceptions, but the exceptions are so rare that it would be outside of standard of care to start the operations and the treatments at the level of the Chiari-2. It would, in our practice and in every place I've ever trained, or anyone who is within the academic pediatric neurosurgery community, our motto and our training philosophy and our treatment philosophy is the only times you operate on a Chiari-2 malformation are dire last circumstances or in patients that are newborns that potentially need more space because of vocal cord dysfunction shortly after birth. There's very few indications to do Chiari-2 decompression surgery.
Okay. So the treatment was dolphin neurostimulation, and whether that is a viable treatment to address pain or function in someone who's not a good candidate for another detethering.
Sure. But, I guess my question was, what is dolphin neurostimulation? I've never heard of that before. So
Okay.
It sounds interesting.
Well, we will look into it. Thank you. All right, so now we have a question, which is, if you have spina bifida occulta with tethered cord and you're experiencing symptoms such as severe pain or trouble walking, neurogenic bowel and bladder, is it recommended to have MRIs of the thoracic and cervical spine?
That's a fantastic question. So spina bifida occulta, I should say, tethered cord can happen in anybody. You do not have to have spina bifida at all, either the open kind with myelomeningocele or the occulta kind, which everything is overall closed at the level of the skin, but there's bone defects. So even though spina bifida occulta doesn't really have an open spinal cord, if you do have symptoms of tethered cord, you treat that patient just like any other tethered cord patient. And to me, the standard of care would be to make sure that there's no syrinx. And in those patients, you have to get imaging of the rest of the spinal cord. You can have spinal cord tethering for multiple reasons, some very rare reasons that don't have anything to do with spina bifida. And so you need to be able to evaluate the entire spinal cord before you can rule out that there's no other causes of spinal cord tethering.
Okay. What are some specific functional deficits or anatomical challenges that you might look for to help determine if there's been an increase in tethered cord or the development of syrinx?
So that's a good question. So part of it is that tethered cord doesn't always obey the rules of individual nerve function. And so when you start to have tethered cord symptoms, they tend to not be very specific. It's not like a slipped disc, which a lot of adults have suffered from, that tends to push on one specific nerve, and so you can isolate that location very well, even without an MRI. Tethered cord is more of a vague pulling and twisting and irritation at the level of the nerves that come out of the spinal cord, not the nerves that are already out of the spinal cord. So these are the cells that then give rise to those long nerves you saw in the video. They're not necessarily pulling on the nerves themselves. And because of that, you can have symptoms that are all over the place. I would say that the classic types of symptoms, if you were to read a textbook or something like that, would be achy pain, not necessarily shooting electrical pain. It would be dull pain. It would be sensory changes that might come and go. You might have numbness, tingling in one area. It might go away and come back in a different area. They tend to be induced by stress. And so stress like exercise, walking, exercise, doing specific exercises of the lower extremities, these tend to require increased blood flow, and tethered spinal cords don't tend to get as good of a blood flow. And so once you decrease the oxygen to those areas, sometimes you'll see those symptoms come on. And as you saw in our patient, her biggest complaints when she was having symptoms was that she couldn't walk as long of a distance. She was getting achy pains and wanted to be picked up. So that's sort of a very classic tethered cord style symptomatology.
Okay. So we have time for like one more question, and then we will be sure to address the rest of them. I think we have 2 or 3 more minutes. So let's see what we can do in 2 or 3 more minutes. By placing a VP shunt at the time of the myelomeningocele closure, ventriculomegaly, by placing that shunt at that time, could that have prevented a syrinx later?
That's a great question. Typically, the thought is that if hydrocephalus is a cause of overall pressure that then goes down and translates to sort of a cork in a bottle effect. So if the brain pressure is getting so high that it pushes the very bottom of the brain down, that's acting more like a Chiari-1 malformation, but it's plugging up the normal flow of spinal fluid even through the spinal cord. In those cases, doing shunt surgery is typically done early on because the pressure symptoms already are showing that there's a problem. In patients who don't need a VP shunt, and the majority of kids with myelomeningoceles nowadays do not get VP shunts, is because we found that just because the ventricles are big, it does not mean that they actually have increased pressure. And so if there's no pressure, if the brain is growing well, if the ventricles are getting a little bit smaller over time, those patients don't require treatment for hydrocephalus, and yet they can still develop syrinx. And so most often the syrinx is associated below the level of the brain. It is more of a phenomenon of the spinal cord and the tethering and the flow within the spinal canal, and not so much the flow within the brain itself. So most cases, putting a shunt at the time of myelomeningocele closure does not prevent future syrinxes. As you saw in that paper that we discussed, about 46% of patients at follow-ups had syrinx, and in those patients, about 50 to 60% might have had a shunt based on statistics. So just because you have a shunt doesn't mean you won't get a syrinx.
All right, we'll do one more. And for everybody else whose questions are pending, we will definitely get them to Dr. Iskandari so he can answer them later. But if adult detethering surgery is being delayed pending weight loss, what specialist should be visited to help manage symptoms?
Wow, that's a tough one.
Oh no.
I think the hardest part in that is symptoms of tethered cord are very challenging, especially in adults. And so I think, pain management is one way to do it. But I would say if the delay is because of weight loss, the first person that I would try and contact would be anyone that could help with that weight loss, honestly. Because most of the time, tethered cord symptoms are not going to get better on their own. And so just managing them medically is probably more like a Band-Aid. If you really do need that surgery, I would do everything in my power to get you to that weight that that the surgeon would feel comfortable doing the surgery.
Okay, great. Well, thank you so much, Dr. Iskandari. We will get you the questions later on. Really appreciate your time. And we'll go on to the next.